So today my task is to share with you a few atypical presentations for hypertension. So hypertension case series was what I was asked to talk about because I think Pfizer has a lot of interest in AF management and hypertension management. So this is where we are today. Okay, a disclaimer, whatever I'm presenting is my own opinion, it's nothing to do with Pfizer. It's just my own personal experience as well as my treatment management modality plans. Okay, just now we forgot to introduce our team. So I think we are the biggest private cardiologist group today. We have two echocardiologists, so we have two heart failure specialists, so Dr. Chuang and Dr. Chan are heart failure specialists. Dr. Goh Ping Ping, as you may know her, she's our echocardiologist as well as does all the exercise stress testing. Pipin and myself are the two electricians, and then we have three plumbers, Stanley, Dr. Tan Chong Hiong, and Dr. Ega. Dr. Ega is also a very talented cardiologist who does structural heart problems, so TAVI, ASD closure, etc. is done by him. So I think among the 8 of us, we should be able to solve more than 99% of any cardiac issues. The 1% that we can't solve may be very challenging to solve also. Okay, this is our whole full range of services. Last 2-3 years, we have embarked on oncocardiology. So myself, Dr. Chan, and Dr. Chuang looked after a lot of the cancer patients because a lot of cancer treatment today actually cause some heart problems from arrhythmias to heart failure. Sorry about that. And then we're also embarking on neurocardiology, where stroke prevention is very important in AF and non-AF patients. So recently we have also had a lot of collaboration with neurologists to close up the PFOs, because a lot of these PFOs may be the cause for those idiopathic strokes. Wan Xian is interested in women's heart, and therefore she is actually one of our collaborators with our ONG partners for women's heart health, as well as we are also embarking on sports performance and rehabilitation for sports cardiology in AHVC. Okay, so today, sorry for the slight glitch in the Apple computer. Okay, today I'm going to talk about hypertension. So look at some overall epidemiological data on global hypertension problem. There's not many new guidelines. So there's a summary guidelines from the International Society of Hypertension called ISH 2020. I will go through that with you. You can always download the full guidelines in nice PDF format on the internet. I'll touch a bit about use of ACE inhibitors in COVID patients, because last year there was a little bit of a scare in most of us, and then I'll go through some case reports, okay, or case reviews. So the global hypertension problem, as you can see in this graph, a lot of patients in the African continent has an average, the prevalence of the hypertension is more than 40%, whereas in the rest of the world, the prevalence is just under 30 to 35%. So it's actually a global problem, and it's a growing problem. If you look at patients in high income class and lower income countries, we do have a difference in our average mean blood pressure measurement. So those patients who are slightly in a higher income country will have a better blood pressure control, most likely due to the availability of treatment and accessibility of treatment, as well as guidelines-driven treatment. And patients who are in the slightly lower to middle income countries do not fare so well in terms of blood pressure control. But having said that, we do have a lot more people in the lower middle income class that has a hypertension problem, close to 1 billion, and only 1/3 of them are from the so-called higher income countries. So back in Singapore, this is, unfortunately, I think most of you who have attended my hypertension talk must have been wondering why I keep using the same slide, because this is the only slide you can find from MOH since 2010. This is our prevalence data in Singapore. As a whole, 30 to 69 years old age group, the prevalence is about 25%. We are also very happy to say that 2/3 of our patients under the good management of yourself, as well as the polyclinic doctors, have achieved good blood pressure control. So blood pressure, we all know, is a risk factor for a lot of cardiovascular disease, but I want to stress that the two most severe forms of complications for hypertension is not AMI, it is more heart failure as well as stroke, right? So stroke and heart failure are the two more severe forms of complications with hypertension. much more than coronary artery disease or peripheral vascular disease. And if you look at all the different AF studies that we have done over the years, the prevalence of hypertension in this AF population is in excess of 50%. So you can interpret this data two ways. You can tell somebody who is in the age of 60 years old, if you have hypertension, you have a 1 in 2 chance of having AF. But vice versa, if I see an AF patient referred to you to our clinic, either seeing me or Pipin, we have a good 50% chance that knowing that this patient may have an underlying hypertension, even though he's under well control. So this is how we can share with patients how common this AF will be, right? The other thing I would like to share is that hypertension and heart failure is not a benign condition. So if you look at this nice little graph, patients who have from US, patients who have HIV, the 1-year mortality rate getting AIDS is about 10%. Patients who have lung cancer, the 1-year mortality rate with good control can be under 60%. Patients who have pancreatic cancer, unfortunately, the 1-year mortality rate is close to 80%. But once you are diagnosed with heart failure and your EF is down, it is very unlikely your EF will fully recover. And once you progress to end-stage heart failure, the mortality rate of that patient is the same as someone who has gotten pancreatic cancer at end-stage heart failure. So 1-year mortality rate is almost 80%. When I was in public hospitals, we always advocate to our residents and registrars, heart failure is not something to be taken lightly for, because you may not see half of these patients in a hospital in 5 years' time, because half of them may pass away because of heart failure or progressive heart failure. Okay, so hypertension, the ISH guidelines, this is last year, May 2020. So, last 2 years, we were all very bothered by COVID and very affected by the pandemic. So there's not many new guidelines update, but this group managed to do some consolidation of major guidelines from the Japanese Society, which was 2019, the ACC AHA, which is the American Society, which is 2017, the ESC guidelines, which I presented some time back 2 years ago, 2018, and as a result, they come up with this collaborative opinion. And I think this opinion is very practical opinion. So if you go into this guidelines opinion, you can actually see that they classify everything under essential or optimal. Essential means bare minimum. It means the least you should do for your patient is the essential things to be addressed. Optimal is standard of care, or what we call evidence-based medicine. All right. So in these guidelines, they actually address a lot of these issues, which I think most of you will have in the daily practice they encounter, and you may want to refer to them. I won't go through all of them, but this list is pretty exhaustive. I just picked up certain things to share. So today I want to share certain definitions and certain treatment principles, and this is under essential. So the essential things we should know, meaning the bare minimum, is we should at least know what is the reference range for hypertension. So I think it is well accepted that anything below 130/85 is considered normal. It's also well accepted that anything more than 140/90 is hypertensive, and then you can choose to use grade 1, grade 2. We also accept that there are high normal people, but these high normal people should not be neglected. They should be managed accordingly with good advice on lifestyle and diet, so that they do not fall into the grade 1 or grade 2 hypertension. So this is something that we all have to understand and remember. And if you look at office blood pressure versus ABP, which is ambulatory blood pressure monitoring, and home blood pressure monitoring, you may have different cutoffs. So I always tell my patients to record their blood pressure at home, look at their diary, BP diary. If generally their blood pressure is below 135/85, more than 75% of the time at home, I think it's pretty acceptable and pretty good. In the clinic, sometimes a bit of white coat, sometimes patients are a bit anxious, sometimes patients are a bit rushing. Sometimes they're upset over other things before coming to see us, and then the BP is a bit high, so ask them to cool down a little bit, take again. But unfortunately, ask them to wait outside another 10 minutes doesn't make things better because they're rushing off, so sometimes the BP doesn't come down. So I find that it's always good to just show me your BP diary. There's probably no reason why there's no reason for them to fake anything at home. So if they show you a very decent BP diary, I would take that as that's a very good blood pressure assessment. Okay. Ambulatory blood pressure cutoff is still 130/80 for average, and then there's a daytime and nighttime cutoff which we use today. Okay, do you have something in Singapore? Yes, we have something in Singapore. This is taken from Straits Times, right? So the most popular magazine in Singapore or newspaper, somebody will call it, it's called Straits Times. And if you read the Straits Times, then this is what Straits Times says in Singapore, 130 and 80 below is considered normal. Prehypertensive is this, and hypertensive is more than 140/90. This came out back in 2017 because there was this push to bring the blood pressure normal down from 135/85 to 130/80. And suddenly you will have another 20% of your patients who are now hypertensive when previously they are not. So this is what the US did. They were even more aggressive. They came down to 120/80. So I think we decided that we will adopt a more moderated approach. So under the treatment modality, there's also this essential component versus the optimal component. It's a very small print, so I think you can take your time to go and look through this in the actual article. But I will look at the summary of the drug treatment for hypertension. It is fair to say that if your patient has uncontrolled blood pressure beyond lifestyle modification, then you should start drug treatment if their blood pressure is above 140/90, not just in your clinic, but also their home blood pressure recording. And if the patient is below 65 years old, we really want to bring them down to 130/80. Alright, that is the target. If they're above 65 years old, well, you can be a little bit more lenient as long as they are below the grade 1 hypertension category is probably good enough. But if you really want to keep them very well, you probably want to bring them to 135/85 or 130/80. But the bare minimum we need to do is if you see your patients with hypertension, whatever drug you try to start them on, try to reduce the BP systolic by more than 20 and diastolic by more than 10. So that's the minimum that we should do as physicians looking after patients with chronic disease. Okay, the second other summary slide is that if you want to start treatment, there's this push towards using low-dose combination treatment, preferably in a single pill combination. SPC is single pill combination, so that you can have the best synergistic effect with the lowest possible dose and hopefully no side effects for the patient. And if you still use diuretics, I think Pfizer diuretics are still very, very efficacious. Just have to be careful about the electrolyte imbalances, but most of the time you should get away with it unless it's a very elderly patient. Okay, what is essential in the drug treatment of hypertension is that if you don't have any so-called ideal agents available for the patient for whatever reason, this probably applies to the lower income countries, then you should still focus on trying to bring the blood pressure down effectively with whatever available means. So I think that's how the guidelines is trying to advocate treatment among the different countries with different affluence. Okay, so with that, let's go through a few clinical cases. I just use these clinical cases to highlight and illustrate maybe some simple principles that I work on. Okay, so the first patient is a 60-year-old female. This is a patient who has hypertension, came to see me in the clinic complaining of persistent headache. You probably will see her in the clinic because she recovered from COVID infection, and I think with 10,000 people getting COVID every day, it's a matter of time before Singapore gets all boosted by natural immunity, right? So 10,000 a day, some will come to see you, some will come to see me for headache. And then if they have headache, it's going to be a chicken and egg, which came first. You measure their blood pressure. I have not measured anyone with a person who has headache with a normal blood pressure. So when you see someone with headache, you measure the blood pressure, invariably it will be a little bit high. Wait for 5 minutes, check again, it's still high. So this is her ECG. She basically has a little bit of left atrial enlargement and first degree heart block, 60 years old, it's not that uncommon. You see the typical P mitrale in the lead 2, and then you see this biphasic P wave, just telling you that most likely this patient has hypertension for a while, the atrium is a little bit enlarged. It is a little soft marker that this person is likely to get AF at some point down the road, but today is sinus rhythm. Alright, so this is just what this ECG shows. And this is just to show the first degree heart block more than 115 milliseconds. So this is the patient's medications, Remipril and Novas and Modality. So the question that this the slide wanted me to address today is, should we stop an ACE inhibitor, right? We had these issues about ACE inhibitors during COVID infection. I think this came out quite strongly in 2020, and there were a lot of articles coming out to say that a lot of patients who have COVID infection, they do very badly if they're on ACE inhibitors, especially they're hypertensive. So it actually prompted the Ministry of Health to do a rapid review, and this was published in 21st of March 2020. This was the background. There were 2 studies that highlighted that patients who have hypertension on ACE inhibitors seems to do badly if they have severe COVID. The reason is because of the ACE2 receptor upregulation, and they think that prompted, because of the use of ACE inhibitor, you will upregulate the receptors, and because of that, the receptors are more I think they can be more readily available to bind towards the COVID virus and cause complications hence. But I think all professional bodies, including our Ministry of Health, have advised that you should not stop the ACE or ARBs in patients who have COVID infection. That means if they are currently having a very mild Omicron COVID infection, if they are on antihypertensive like ACE or ARB, please continue them on it. You don't need to stop them, and you have good supporting evidence to say so. And I think there is no clear evidence that patients who are on ACE or ARB today increases or become more susceptible to severe COVID infection. Right? This is one of the slides that I used in my previous talk with COVID and heart. So essentially, the cartoon is to demonstrate that if you have a COVID virus, and the COVID virus, the SARS-2 COVID virus has got this receptor spike protein, which has an affinity for the ACE2 receptor protein, which can be found in the heart as well. So the direct association can lead to myocarditis. It is not common, but it can happen. But if you upregulate it, we don't know whether is there any evidence to say that it will happen more. But the other mechanism that causes both vaccine as well as infection-induced myocarditis would be the immune response. So a lot of the immune response mediated ones may or may not be directly related to the upregulation of the ACE2 receptors. So this is a common sequelae. It's first published by the Wuhan group, who has seen a lot of patients either recovering or during the COVID infection. If they are not in septic shock, they have a lot of hypertensive problems to be managed. So hypertension is quite common in patients as a sequelae with after COVID infection. So if you do see your patients coming back to you after they recover from their very mild COVID infections and the blood pressure is up, which I've recently seen a few, just up-titrate their medications for 1 to 2 weeks, review them again. Most of the time they are self-limiting and you'll go back down on its own. In fact, I always leave them with the instruction, if your blood pressure at home is coming back to what you had before, and most of them do have their background numbers, they can reduce the medication back to their original dose. Right? But during the initial period, there is nothing wrong with just increasing their dose. You don't need to increase by adding more medication, you can just up-titrate the dose. And I think these two articles just for me to remind you that this can happen also in patients who have gone through vaccination. So I personally have seen patients going through vaccination after the second and third dose coming in with labile hypertension. First thing first is you exclude stroke, because you want to make sure that this patient didn't get an acute stroke, because if it's an acute stroke, you do not want to increase the blood pressure medication too much suddenly, because that is a hyperreactive reaction. So do a full clinical examination. In doubt, if you can send the patient to do an MRI, do an MRI early. So some of them present to the hospital in A&E, we'll do an MRI to make sure there's no acute stroke, no bleeding, and then we can commence antihypertensive treatment. This is also published in the Hypertension journal, saying that stage 3 hypertension in patients after vaccination is not uncommon. It can happen, and you just have to be aware that if it happens, you just need to react accordingly. Okay, hypertension, as we all know, is not a simple condition that can be treated with one drug. So if you use one drug only to control hypertension, very likely this patient's hypertension is very, very mild, or what we call prehypertension. Sometimes you get away without any medication if they do a lot of lifestyle modification. Most studies, all studies shows that minimum is 2 antihypertensive to obtain the trial blood pressure achievement. So looking at the trial blood pressure achieved in the old days, it's not too bad because we generally try to bring them down to below 135 systolic, and then I think that's a very good range to get, except for maybe UKPDS and renal study and maybe the our head study. The rest are all quite close to 135. So up to 85% of patients we know definitely use multiple medications. And I think today, if you have resistant hypertension, it means you have used everything and at very high doses, and the patient is starting to get side effects, starting to get hyponatremia, hypokalemia, for example. You can't up the thiazide diuretics anymore. You may want to send them to us for an opinion whether or not these are resistant hypertension and how to manage them. In resistant hypertension, some years back, there was a treatment called renal nerve denervation that was popular, but it went, unfortunately, they did a wrong study. It went downhill because it was no better than a sham procedure. But I think they came back in and they went to do a proper randomized control trial this time round with the correct setup. And it was published in Lancet not too long ago, about 1.5 years, showing that it does help to reduce the blood pressure quite significantly by up to 9 millimeters mercury. may not be a lot to all of us. 9 mm mercury is really not a big deal, right? But if you reduce it by even 1 to 2 mm mercury, you get significant cardiovascular protection. So for patients who are on optimal medication and they cannot get blood pressure down, then there is still some other forms of invasive treatment that we can offer. But I think from my experience, I'll probably share with you that if your patient is on polypharmacy with 3-4 pills, there is also a very good chance that the compliance may not be as great as you want it to be. So if you can simplify that regime for your patient by using SPC, single pill combination of 2 or 3 different drugs in 2 pills, you may be able to see a sudden improvement. So the first thing I normally do when patients come to see me for second opinion on hypertension management, I look at their drugs and then I see if I can simplify it. If I can simplify it and I still cannot get a targeted result, then of course I think we can look at other treatment options, right? The second thing I will do is to identify what is the underlying trigger or cause. So somebody who has got good blood pressure control suddenly don't have good blood pressure control, there's usually often a reason, and we need to understand what the reason is. Is it a recent vaccination? Is it due to coronary artery disease? Is it due to certain other conditions like obstructive sleep apnea? Okay, so this second case is to remind me of something to share with you about looking for triggers, right? This is a 40-year-old male. As you can see, the BMI is very high, so he's overweight, near obesity. He saw me because he was on a routine health screening and the BP was a bit high in the health screening center. So he went home and he did his own blood pressure check and he said, actually my blood pressure at home is okay. I always get 135/85. So for the very savvy Singaporeans, right, they know what the reference range is. They will always tell you, okay, my blood pressure at home is okay. It's not above that magic number. Then you will not have to trigger your reaction. So they will say, it's not that high, it's 135/85. So it's a bit borderline, right? So this was his ECG. If you look at his ECG, you will notice something is not right because his ECG shows quite a lot of tall R wave, deep S wave, a bit of T inversions in V5, V6, lead 2, lead 1. You suspect this patient may have hypertrophy, left ventricular hypertrophy with strain. So you can apply the 2 textbook rules. One is Sokolov's criteria and the other one is Cornell's criteria. They are not that difficult to remember. In Sokolov's criteria, you just look at the S wave in V1. So you look at the S wave in V1, which is here. This is deep 1, this is the S wave. And the R wave in V5 or V6, whichever is larger. So if you look at V5 and V6, the R wave, whichever is larger, count the number of squares total from here to here plus here to here. If it is more than 7 squares, then most likely this patient has got LVH, left ventricular hypertrophy. But if, like this particular ECG of mine, and I think sometimes you will find it challenging, you can't really see where the S wave ends or where the R wave ends because it overlaps so much, then you can use the modified Cornell's criteria, which is S wave in lead V3, as well as R wave in AVL. So S wave in lead V3 is here, and then R wave in AVL. If you add them up together and you again get more than 30 or 3 small squares, then definitely your patient is likely to have left ventricular hypertrophy. Again, if you're not sure, send to us for an echo and then we can take the actual measurement and let you know. So this is a typical ECG of a patient who has got long-standing hypertension maybe and unaware and has left ventricular hypertrophy. Okay. Is this hypertensive heart disease? Well, if you look at the definition of hypertensive heart disease, the hypertensive heart disease is usually defined by a constellation of abnormalities, including left ventricular hypertrophy, systolic and or diastolic dysfunction, that is quite severe for systolic dysfunction, and clinical manifestation including arrhythmia and symptomatic heart failure. So if this patient only has LVH, probably have some diastolic dysfunction because of the enlarged thickened ventricular muscles, but does not have any arrhythmias or symptomatic heart failure as of now, then it's not officially classified as hypertensive heart disease because the whole constellation should be present before we jump in and say someone has got hypertensive heart disease, right? So this is hypertrophy, atrial enlargement, muscle thickening, so all these are constellation. So someone would then use this ECG and say, okay, so is this left ventricular hypertrophy? So if you look at the criteria here, you probably would suspect it if you look at the Cornell's criteria, but if you strictly count it, it's not going to be more than 3 squares, so it's not more than 30 millimeters. And clearly, the S wave in V1 and the R wave in V5 or V6 does not fulfill the so-called criteria. So this patient on ECG doesn't look like there is left ventricular hypertrophy, but there's a lot of T wave inversion. So this patient has another condition called hypertrophic cardiomyopathy, where you have thickening of the heart muscle, but it's not because of LVH, it's more because of abnormal thickening of usually the apex or the septal wall of the heart muscle. So this again we'll confirm using a 2D echocardiography. Okay, so the next step for that patient, a 40-year-old patient who has a BMI of 30, what should we do? Do an echo, do an ABP, or refer cardio? There's no right or wrong answer. Some of you refer cardio, some of you send to us to do an ABP because the clinic pressure is high, the home pressure is normal. So I think doing ABP is good. And if you do an ABP, you should be able to get this kind of graph. A normal 24-hour ABP will show you nice reference range of systolic and diastolic within the green bar, and then there's a dip when you're sleeping. This is somebody who has got hypertension. Both the sleeping time, nighttime and daytime, the blood pressure is high, both systolic and diastolic often. And this is what we call nocturnal hypertension, whereby maybe like this patient, you can't really see the high blood pressure in the daytime because he measures it at home. But in your clinic down here or down here might be spikes because of white coat effect as well. But at night, clearly he has hypertension, and this patient will never know he has hypertension at night because no one wakes up to record their blood pressure in the middle of the night for nothing. So nobody records their own blood pressure at night and they sleep through. So this is where a 24-hour ABP will be able to pick up. So this patient of mine has nocturnal hypertension. This is the graph that we will generate and send to you in the report, and you can actually see that the nocturnal night blood pressure is a bit higher than the day pressure, right? So the day pressure is also not totally normal. He's correct to say that his average is 135/85, right? Because on that reading here it's also 135/85. So sometimes patients don't really kid us, right? It's just that they sometimes don't believe that what we're telling them in the clinic just because of one consultation. So this, I think, is something that patients will accept because they can see for themselves that there is some problem. And then we have to find out what happened to you at night. Why is your blood pressure at night, nocturnal blood pressure high? Are you a night worker? Are you a night shift worker? So there's some reasons to explore, right? So I did an ABP. This was the number. He's young. Definitely he will need some form of young hypertensive workup. I think 40 and below I still do young hypertensive workup. Definitely he needs to do something to his BMI. And then I will ask him to consider a sleep study. Why? Because OSA is present in almost 80% of patients with drug-resistant hypertension or just all forms hypertension alone, up to 35%. If, like what Dr. Pipin said just now, if you have AF and we send them routinely for sleep study, we will pick up half of them have at least moderate to severe OSA, even though they don't think so and they don't feel the symptoms. But if you ask the spouse, if the partner comes with you and you ask the spouse, does your husband snore? Does your wife snore? It's almost 100% yes, and it's always very loud. So they always say yes and it's very loud, but it's always been like that all these years. So always been like that all these years does not usually imply that there's nothing wrong, right? So if you have hypertension, you're starting to get a rhythm problem, you should do a very simple sleep study. Okay, this is my last case. This is the most interesting, unfortunate case. 56-year-old man is an Italian. He was working in Jakarta since 2014. He's here. Then he came to see me. He flew in every now and then whenever he comes to Singapore for meeting to see me for his hypertension management. So I've been seeing him since 2014. He has been on this good medication or combination pill which I use for him, CCB, ARB with a thiazide diuretics. And then 3 years back, he came back complaining of recent onset headache, neck pain, noted the blood pressure to be suboptimal, always hitting 150, 160 when normally he gets below 140, 90. I think he's quite a big size Italian guy. So the wife also commented that he's easily more agitated and mild memory lapses. So he was also having some cognitive not change in sensorium, but everyone thought this is related to stress because he was relocating to Singapore. There was a lot of issues with the company and trying to move on to a new company. But anyway, in any case, just when I see someone like that coming to see me in the clinic, or someone I've seen long ago for a long time, I normally will do something because I think it's not common and not normal. So I admitted him. Since he has so many neurological symptoms, I admitted him to a cardiac, this MRI stroke screen and MRI brain. So unfortunately, MRI brain shows this, and I think you don't need to be a radiologist, neurologist, or neurosurgeon to see a hole in the brain. A hole in the brain here means there is a space occupying fluid, and then you see this edematous part of the brain, which is a tumor. So he was having this tumor that was growing and causing a little bit of space occupying lesion, hence causing his blood pressure to be more labile. So this presentation is very atypical. It's not something you will see all the time. It's something that I didn't expect to see, but when you see it, you've got to act on it. He subsequently was diagnosed with a malignant glioma, had surgery done, had gamma knife as well, had radiation therapy, and is in remission. And then after the surgery, the blood pressure, of course, improved. So I actually planned for him to do an MRI and a sleep study. But when the MRI came back, obviously, there's no need to do the sleep study anymore. We found the cause, and then we quickly treated the cause. Had to give him a quick, had to give him some IV dexamethasone overnight just to make sure that the cerebral edema is under control before the surgeon can offer him definitive surgery. So this is just to share that whenever you have a good patient on good blood pressure control and something triggered him or her to see you with a change in blood pressure, take a little bit more history, see if there's any other associated symptoms, and then send the patient for relevant tests. Okay. So with that, I just want to end by just sharing three take-home message. I think hypertension management definitely in most situations will require polypharmacy, and if you have to use polypharmacy or more than one medication, single pill combination will improve results and compliance for sure. I think the blood pressure aim today is really just to hit below 130/80. You can be more aggressive if you want to go below 120/80. I think there's nothing wrong if you want to stick to 135/85 or wherever it is. We choose good medication and advise our patients accordingly. And lastly, just remember that my last two patients, always consider triggers. So if somebody has got labile blood pressure, it just doesn't happen for a reason. There must be something that has triggered it. So if you're on good medication, assuming you have not been someone who has been taking medication on and off, then you should not see labile blood pressure changes, and therefore always think of the underlying triggers. All right. So with that, thank you very much, and I think we can do some Q&A.